morning, everybody, and very welcome to the fourth episode of this Clinical Case Corner. And today I'm very glad to introduce you Professor Alaide Chieffo, which would be our expert for the case of today, which all of you know, of course, but is the first woman which is PCI president, and is also from Naples, like me. So another tick. And Mario Iannaccone, which is a member of our GISE Young board, which will be our presenter for today. And he will present us a cardiogenic shock, a clinical case of cardiogenic shock in a STEMI patient with LV support. So I give the word to Mario, and there will be a stop, and then Alaide will show us some slides and the key points. And at the end of the presentation, you are able to ask questions in our chat, and I will read the question for Mario and Alaide, of course. So Mario, you can start.
Thank you, Federica. Good morning to everybody. It's a great pleasure to be here with you. Let's go straight forward to the case. So this is a case of cardiogenic shock. So the clinical presentation is a 61-year-old male with a lot of cardiovascular risk factors such as hypertension. It is a smoker, hyperlipemia, no significant comorbidities in the past. In November, he experienced chest pain, and he alerted the emergency setting, the 118. And this is the ECG transmission to our hospital, and it is a clear ST elevation myocardial infarction in anterolateral leads. Next, please. The patient is transferred to our cath lab directly from the territory. And once he arrived in our cath lab, he is sweatened, he confused, he has still chest pain, he is hypotensive, blood pressure 90/60, he is going to be bradycardic. The first hemogas analysis show a normal pH but increased lactates 4.87. Fast echocardiography show really low ejection fraction, 20% with the anterolateral, posterior, and apex akinesia, but a normal right ventricular function. No inotropic therapy was initiated during transport. The colleagues just initiated aspirin and heparin. So, what's the shock stratification? What's the shock phenotype and strategy? I would like to share the podium with Professor Chieffo, our expert.
So thanks, Maro. That's a great case, very interesting case. If we can go to the next slide. Okay, so just a reminder, because clearly we are now, after discussing this case, after the publication of what I think is the most important trial, at least of the year, and this is the first positive trial that we have in the treatment of STEMI complicated by cardiogenic shock. Just to remind you, the danger shock criteria, there was an ST elevation MI with hypotension, hypoperfusion, first episode within 6 hours, reduced LVF, and the patient were randomized when shock was diagnosed. Indeed, the exclusion criteria were the presence of out-of-hospital cardiac arrest, comatose, and right ventricular failure, so the presence of biventricular failure and mechanical complication. So how this patient, the patient of Mario, met the criteria of danger shock? The patient met all the criteria because the patient presented with an ST elevation MI, first episode within 6 hours. The patient was hypotensive, 90/50 was the arterial pressure. Lactates were 5, so more than 2. LVF was 20%. And it did not met the exclusion criteria. It did met the exclusion criteria because it did not have cardiac arrest, no right ventricular failure, no mechanical complication. So this is a classical patient from danger shock. And again, the median age of the patient of Mario was, if you can show all the arrows, 61 again. It's in mean with danger shock. The patient presented 1 hour from the onset of symptoms. And by the way, congrats to Rin area and organization. It means that there is already on board a kind of network of cardiogenic shock, and we know golden hour is fundamental for this patient. Lactate of this patient was 4.7, the mean in the danger shock was 4.5. The median of danger shock was 25% of LVF, in this case 20%, and the SAP was 90, and the median value of the danger shock was 82. So Mario, tell us, having your patient meeting the danger shock criteria, how did you treat this patient? And then maybe further on we can discuss if your practice was influenced by the result of the study.
Indeed, this case happened before the danger shock, so no, because it was in November. So we just started a low dose adrenaline infusion, just to and non-invasive ventilation. Then we assessed an echo-guided right femoral access, and I placed just one ProGlide, and I placed Impella CP directly before angiography. Then with a single access approach, this is the first shot that I had, and it's a clear left main disease with thrombus in distal left main and ostial LAD and intermediate in ramus intermedius. Next, we went through the PCI with thrombus aspiration. Next, that was effective. Then standard left main to LAD PCI with the normal just standard step recrossing kissing balloon pot and repot. Next, and this is the final result that was quite good with TIMI free flow on LAD and ramus intermedius and left circumflex. Next. The patient was transferred to our ICU, where, of course, the Impella was left on place in definitive assessment. The position was checked by transthoracic echocardiography because it was quite good. These are our patient hemodynamic and biochemical markers. There was lactate clearance in 24 hours. As you can see on the table on the right, there was not creatinine increase in baseline and 48 hours. The hepatic biomarkers that were increased at the baseline have a really good washout at 48 hours. And also bilirubin did not increase. Is not in this case we check bilirubin not for hepatic damage, but due to some hemolysis that the device may have in this kind of situation. The concept here is to stop the inotropes as soon as possible. So we stopped the adrenaline just after the procedure because we had a good mean perfusion pressure at the end of the procedure. Then we assessed the lowest P Impella value as possible to maintain a good perfusion and to not have a lactating clearance. So then at 48 hours, we tried to win the patient, and we were successful in winning him, and we removed the Impella CP at 48 hours, more or less. The in-hospital stay was characterized by anemization and an epistenocardia pericarditis, so we started colchicine. And we transferred the patient to rehabilitation, but at 6 days, but with a good ejection fraction of 47%. Next. So, thank you. This is my case. I share again the screen with Professor Chieffa. I cannot hear you. We cannot hear you, Alain.
Okay, I was on mute. So clearly we will discuss this patient. There is so much to discuss. However, some take-home messages, I think, consider a temporary mechanical MCS, microaxial flow pump, because what is important is that very often it is used the term MCS. MCS is a family of different devices. This patient was meeting the danger shock criteria, and in danger shock, the device that was used was a microaxial flow pump of the family of Impella CP. So if we focus on this case, we should consider the use of this device early and before primary PCI to maximize myocardial recovery in AMI SCS patient, and according to the trial, or also to reduce mortality at 180 days. If you use microaxial flow pump, do a careful access site management, as you did, with ultrasound and angio-guided puncture. Take care of the closure of the access, pre or post closure. In this case, Mario was using a pre-closure with one ProGlide. And that's very important because, as you know, probably the danger shock is a positive trial. However, there was a significant increase in the rate of vascular complication with this device. So in the modern area, we have to take care of the access and be sure that the benefit on mortality of this device are not counterbalanced negatively by the complication because of a bad, careful access site management that indeed Mario did not do. He did a perfect access site management, and in fact, the patient had no complication. Consider down and up escalation of these devices according to the clinical course. In the case of Mario, there was no need for up escalation, and so therefore careful assessment of the patient. There was a down escalation, clearly early down titration of the inotrope, which is the key, by the way, and the patient then could have been weaned, and then the device took out. And last but not least, clearly a shock team is fundamental, because it's not only to put the device in place, is first early recognition of the patient, because it's fundamental that people have an education of how to promptly diagnose cardiogenic shock. We know quite well that when you have a frank shock, the outcomes are better than indeed when a patient presents, for example, with the SCAI-B and have an escalation and progression of disease, and in this case they go worse, which is a paradox, but means only that we are not well educated to the different class of the SCAI shock. And then it's important how the patient is managed, not only the cath lab, but after, from the intensive unit care. So if you set up a cardiogenic shock organization, you need to have a multidisciplinary team approach and be aligned also with your intensivists, because clearly a shock team brings together complementary expertise, and I think is the key to success in cardiogenic shock. Now, I think we can open to discussion if there are any questions coming. I mean, we are glad to discuss.
Okay, thank you very much. Thank you, Alaide, and thank you, Mario. This is a very interesting case. And I have a question for both of you. What is your standard approach in shock patients? Okay, we know this is a shock C SCAI, and so Impella first, and directly with guide catheter and so on. But could you give an advice for interventional cardiology who wants to start a shock approach with Impella, who maybe are using Impella but not in a shock setting? Of course, we have to be very careful with access, and this is good, like they told us, with very careful manner. But could you give just tips and tricks to a young cardiologist which goes in cath lab at 1 p.m. with a shock patient and STEMI, anterior STEMI, and wants to put Impella?
I mean, my advice is that you should not do by alone, in the sense that you need to have people in intensive unit care that are trained how to manage this device. I mean, that's the first point. the fact clearly you need to have first been trained in high-risk PCI. So you should have already an experience of Impella use in elective setting. That's fundamental, not only because you gain confidence with the device itself, but also because all the team is aligned, because that's the main problem. It's not only to insert the device, but who is taking care of the device out of the lab, because the outcomes of this patient are driven not only from what you do in the car lab, but I would say also and at the same level from the ones that are handling the patient later on. So if you want to set up a program, all the hospital and the department have to agree on your program as well as your administration. Having said that, I do believe, however, that there is a need for the setting of a network where you have different level of expertise and also according to capability of the hospital. So, which means economical capability, because you have to be ready to up escalate if the patient is not going well, which means, for example, transaxillary or surgical countdowns with more potent agent. You have to be able to, if you have biventricular failure, put an ECMO on or another Impella, and then have a plan for this patient, because this can be also to recovery, but if the patient does not recover, then you have to think about other strategy. So it should be an hub and spoke model where the spoke can be different level according to expertise, but as I think it's important to say, I know there is a lot of enthusiasm because of the positivity of the trial. We are all very happy. I'm doing this since years. Even before the trial, and all the centers that are doing that are very happy of that. But we have to be careful, because this is an amazing technology and possibility to reduce mortality in our patient, but in a careful manner. For us as interventional cardiologists, with all the steps we said, but also to set up programs and expertise. Otherwise, the benefit can be hampered by all the complication. That's the point.
Thank you.
I totally agree with Alaida. This is a teamwork. Is not something that you can start your alone. You need your team covering your back, and everybody must agree on the strategy. Totally 100% agree with Alaida.
Okay, we have a question from the audience. Francesco Bruno asks, regarding the latest trial on CS, what is your opinion? What is, in your opinion, the reason of the different result between danger and then ECLS shock? A matter of device or a matter of patient selection?
I mean, it's a combination. I had to discuss this trial with Olga Tiene last year in ESCA in 7 minutes. I mean, it's a completely different trial. First of all, the device is different. So everybody knows that ECMO can increase the afterload, and you need to unload the ventricle. Otherwise, you don't have the recovery of the left ventricle. And clearly it's patient selection, because in the inclusion criteria were included patients with cardiac arrest out of hospital. And by the way, 77% of the patient in SELS shock had a cardiac arrest out of the hospital. And another important point is that the median time of that study to rehab a sinus rhythm was 20 minutes. It's a long time. Mean lactates were very high, 7. And then the other important issue is that there was 50% of the patient in SLS shock with SCI-C. That it's quite interesting, because honestly, I've never implanted an ECMO for a cardiogenic shock C. It makes for me no sense physiopathologically. And then the other problem were procedural, because in that trial, 9% of the patient never had an ECMO implanted in the treatment group. And what is, again, very important is the fact that despite in the protocol, it was clearly stated that it was recommended to have mechanical unloading, they did not do. Only 5% of the patients randomized in the ECMO trial indeed had mechanical unloading. And as we said, physiopathologically, without unloading the left ventricle, we can expect the increase in the afterload, and this is not optimal. So it's a combination of patient selection, very important, and device itself, and also not following the protocol and not doing what is suggested with ECMO device. Nevertheless, this is a neutral trial, and there is still a niche of patients indeed that benefit from ECMO, and we have to keep it in mind because that's very important.
Okay, we have just two questions on the same, which are quite the same, so I'll ask you the two. Lorenzo Tua asks, do you always pre-close in the setting of CS when impella is expected to remain in place, also after the procedure is done? And Giulia Masiero asks, which are the possible vascular closure management for impella implantation?
Mario, it's your turn.
Okay.
I try to place at least one ProGlide in all the cases, at least one, for two reasons. First, because it's easier to remove the impella when we win the patient. Second, because it helps also to manage the eventual bleeding in ICU. I mean, once you place a ProGlide, you can little bit close the ProGlide. Once you when you have finished your procedure and the patient is in the ICU and you remove the impella sheet by the peel away and you go for the definitive system, which is a little bit smaller than the impella sheet, you can have some perisheath bleeding in that case, especially in older patients with more stiff arteries. In such cases, you can close a little bit the ProGlide inside the sheet and reduce the bleeding. So it helps also in this setting. We can also, if you have not enough time or not enough expertise to place the ProGlide fastly before the impella placement in an urgent setting, we can also place nothing, and we have several kind of a strategy to close to close a 14 French afterwards. We can use several post close technique with ProGlides or also double angioseal, or in some cases if the patient has not is not fat and is easy to compress, also just one 8 French angioseal, a little bit of compression. Anyway, it's not a really big issue in my mind to the impeller removal. I have not a great experience with Manta. Indeed, if you have a great experience with Manta, it's a valuable option too.
Okay, thank you, Mario. Another question from Antonio Soropago. Great case. Question for the expert. What impact do you think that the EnderShock trial will have on the guidelines?
I mean, it should be, first of all, unfortunately, the guidelines were published last year in 2023. I mean, we proposed an update of the consensus document that we had in the past with ACVC. Next step, we try to propose an update of the guidelines. This will be a very hard battle, I have to say, but we can do that. In the meantime, clearly, this will impact is a positive trial. Unfortunately, to have a 1A, you need 2 positive trial or 1 positive trial and meta-analysis. We will discuss, or whoever is in that task force will discuss for a 2A or a 1B. That's the point. But for sure, a positive trial impact on guidelines.
Okay, another question from Attilio Leone. Regarding the timing of impella placement, it is always advisable to put it before PCI, or it can be placed also immediately after flow restoration. And I also had another question to this. Which is your standard for weaning? According to lactate, to clinical status in general, what are the criteria you use?
So the question is if when you decide to use an MCS put before the primary PCI, yes, for sure. Okay. I mean, we have evidence, by the way, the randomized clinical trial requested that you had an impella on place before doing the primary angioplasty. My personal, our experience as a center, we do this even before the angiogram, because in my experience as shock center, I had patient collapsing just because of contrast media injection. So my suggestion in the center that are doing this, and have all the criteria to be doing this, and we already discussed, when you have a patient in shock, the first thing you have to do is to stabilize hemodynamically the patient and implant an impella, and then you do coronary angiography. Because we did not discuss, the trial is positive in obstructive STEMI complicated by cardiogenic shock. But in my personal experience, and by the way, these are also the data from the IMPIT, there are also patients, for example, with MINOCA that can benefit being in cardiogenic shock and being ischemic with the MCS on board. So the first thing you should do is to stabilize hemodynamically the patient, put impella in, and then you do the coronary angiography. I mean, this is my suggestion, because it can collapse just because of contrast media insertion. And then to do this afterwards, it's hampered by all the complication, because then you have to be in a hurry to take that vascular access after you have given heparin to get the radial artery access, and most probably you will have a high likelihood of having the vascular complication. You cannot do what is the best practice that Mario illustrated in his case. On the winning, again, this is an art team approach, not art team, multidisciplinary team. I'm very, very lucky, because when I'm there at 3 o'clock in the night, together with me, there is a team. So we have the cardioanesthesiologist, we have the cardiologist, we have the perfusionist, but it is Raffaele. So I accept this cannot be translated in everybody practice, but just to give you an example, we do always the echo guidance of impella. What I mean that after I position the impella, I have a check on where is the impella, because we had some data that were published regarding malrotation. And honestly, with all my big surprise, having been a TAVI operator, is that when I thought that the device was in apex, actually it was not, and I had to reposition. And the same thing is done the winning. The winning is done by our intensivists, and they have a very comprehensive approach. Clearly is the clinical course of the patient, is the lactates, and the capability to tolerate the winning of the device. So there are different parameters that have to be taken into account, but again, your intensivists have to be trained to do that. There are different programs done by the company. There are also different sessions that can be done in scientific congress that I think is better, because I think this should be not sponsored. And hopefully soon we will have also something that is designed as educational courses by EAPCI, by the way. So again, this is very comprehensive, but just to give you the design, how complex it is to put on board a cardiogenic shock program.
Okay, I think we have time just for last question from Giulia Matero again. What more evidence do we need to convince interventionalists to shift from DTB to DTU?
You know, Dr. Tualo then is also another concept, because it is ongoing, a trial with the SKY B and SKY A, ST elevation MI, anterior MI. Let's see the result. You know, it's a randomization, 30 minutes of unloading. I can say that interim is positive, by the way, and that's very, very interesting. But we need to see the result of that trial. We know that the trial will be terminated before, because they got the power before getting the total sample size. So for the cardiogenic shock, I think we do have, I mean, from class C to E, we have evidence from this trial. It will impact on guidelines. If we want to have an 1A, we need another trial or meta-analysis. And then there is all the rest of the story regarding the unloading before even not SKY C. And we are waiting for the result of the D2 study.
Okay, I think we can conclude now. Thank you very much to Mario, and thank you.
Thank you.
And I think we can wrap up this interesting case, telling that the team is fundamental, and now we have evidence, so we have to put Impella in STEMI shocked patient, but we have to learn how to do it, and we need to study, we need to train, and we need a team which have to support us. Thank you very much. Thank you all.
Thanks to you. Very good work. Great
Thank you very
initiative.
much. Bye bye. Have a good day.
Bye bye, everybody. Thank you.